Okay, it's 6 o'clock. Good evening, everyone. Thank you for joining. It's Tuesday evening. Thank you for coming to this webinar. It seems like it's a very popular one, this webinar. And we are focusing today on the changes to the provincial opioid use disorder guidelines and what pharmacists need to know. My name is Ann Johnston. I'm the Director of Pharmacy Practice Pool with the BC Pharmacy Association. And I would like to begin by respectfully acknowledging that the land on which we work on is on the traditional and ceded homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. And we recognize that the ongoing criminalization, institutionalization, and discrimination against people who use drugs disproportionately harm Indigenous people, and that continuous efforts are needed to dismantle colonial systems of oppression. And we see our work connected to these efforts and hope that as a whole, we contribute to a system that provides safe, respectful, and evidence-based care. And so do please take a moment to also acknowledge where you are joining in virtually from this evening as well. Before we get started, if we go into the next slide, please, I would just like to say that my colleague Andy, you would have received an email from Andy at the BCPHA to a pre-webinar survey link. So this was emailed to you today, and it's also the QR code is up there. If not done so already, would be so grateful if you please can complete that very short webinar. There's only about 5 or 6 questions. It's very short survey. And then towards the end of the webinar, we will post a link to another short post-webinar survey in the chat box. And then when you've completed that, then you'll get your letter of participation for one informal CE. I would like to mention that with any questions, please type them in the Q&A function, not the chat function. So you can see with your sort of your Zoom icons, if you could use the QA function to have if you have questions to type in that would be great. And we've extended this webinar until 7:15 this evening, so we'll get through those questions. We'll get go through as many as we can. This session is being recorded, and so it will be available to view in the BCPHA e-training portal, and we will have a copy of these slides as well in the BCPHA training portal. So I'd like to introduce Mona. Mona is our speaker this evening. So Mona Kwong is the director for the BCCSU Clinical Addiction Pharmacy Fellowship and is the pharmacy advisor at BCCSU. She supports their clinical education and research teams. She supports their educational initiatives such as the BC Echo series on substance use, and as well supports the guideline development such as the alcohol use disorder guidelines, and of course what we'll be discussing this evening, the most recent OUD guidelines. As well, Mona is one of the BCPHA's OAT training facilitators, so many of you may have seen her in our virtual OAT workshops. And in addition, Mona continues to practice at an urban community neighborhood pharmacy, and is also a pharmacist consultant at Infinity Clinic, which is Vancouver's first collaborative medical specialist clinic. And finally, Mona also holds an MPA, a Master's of Public Administration from Queen's University, and a clinical doctorate in pharmacy from the University of Florida. And so with that, Mona, I'll pass it over to you.
Thanks so much, and thank you so much for joining us this evening, especially after work. So just want to go over by the learning objectives. Next slide, please. By the end of this session, just so that you're aware, you'll be able to describe the updated key recommendations in the guideline, apply recommended principles of care when treating opioid use disorder, apply updated dosing, titration, missed dose protocols, and take-home dosing protocols to opioid agonist therapy, or OAT, apply the College of Pharmacists of BC's updated PPP 66 OAT and their policy guides for the bup-naloxone and also methadone and slow-release oral morphine, and finally apply the clinical and regulatory changes in example case studies. So we'll have a few case studies at the end of this session. So just a history. In 2017, more than 6 years ago, the BCCSU released BC's first provincial guideline for the treatment of opioid use disorder. When it was released, it was actually first of its kind to recommend buprenorphine naloxone as first-line opioid agonist treatment for OUD, recommend slow-release oral morphine, SROM, as an alternative option or treatment option for OUD, and also includes harm reduction services as standard of care. So why the update? It's been 6 years, so we are aligning the BC OUD guideline with the new evidence and also clinical practice changes over the years. We're also updating to meet the evolving challenges that resulted from the unregulated fentanyl and other toxic substances, such as high opioid tolerance, which you have had some news about. So since 2016, when a public health emergency was declared in BC, up to about 2022, at least 9,760 British Columbians have died from from opioid toxicity. So although every part of Canada has been impacted by the opioid crisis, BC has both seen the highest number and the highest rate of unregulated toxic drug deaths. Within BC, Northern Health Authority had the highest rate, while Fraser Health Authority had the highest number of toxic drug deaths in 2022. Fentanyl was actually detected in approximately 86% of overdose deaths in 2021 and 81% of toxic drug deaths in 2022, which represents substantial increases from 10 years ago, around 2012, when 3% of deaths involved fentanyl. An investigation of whether drug-related deaths between 2015 and 2017 involved prescribed or non-prescribed medications revealed that 83% of deaths involved non-prescribed opioids, with fentanyl or its analogs being the most prevalent type of opioid detected. And it was found in about 79% of deaths related to non-prescribed opioids. The prevalence of fentanyl in the unregulated drug supply has led to increased opioid tolerance. And this is reflected in the guideline update. In 2023, that was about November, updated clinical recommendations and guidance on the full continuum of care for OUD was based on new evidence and clinical practice changes. We also added comprehensive principles of care, which I will go over. There's updated protocols for dosing and titration, missed doses, and take-home dosing, and also considerations for providing care to specific populations. So I'll go through principles of care. In essence, the updated guideline features several overarching principles of care to facilitate collaborative partnerships with individuals and families experiencing opioid-related harms. So principles of care include patient-centered care. Clinicians should strive to provide care that is respectful of the unique needs, values, and preferences of each person. Individuals should be empowered as experts in their own care. Their social determinants of health. Opioid use disorder should be viewed within a larger societal framework that is shaped by inequalities in the social determinants of health. And so when appropriate, clinicians should also aim to address disparities in the socioeconomic determinants of health by connecting people with resources that meet these needs. So such as housing, food, nutrition, financial assistance, and also employment. Indigenous cultural safety and humility is part of this. Clinicians should make meaningful commitments to providing cultural safe care and practicing cultural humility in order to establish safe and positive partnerships with Indigenous people, families, and communities. So the College of Pharmacists of BC, as a reminder, has adopted the Indigenous Cultural Safety, Humility, and Anti-Racism Standard Cultural Safety and Humility Training for Pharmacists is also available through UBC's Faculty of Pharmaceutical Sciences. So you can have a look at that. Anti-racist practices, confronting and interrogating racial structures in healthcare and building awareness of one's position within oppression systems can also help improve care engagement and health outcomes for communities facing racism. We also went through trauma and violence-informed practice, from being familiar with and incorporate principles of trauma and violence-informed practice to the care and clinical management of people with OUD with the goal of creating a safe and respectful environment that minimizes the potential for harm and traumatization. Recovery and self-defined wellness, validating individuals' goals in OUD treatment and care, which may include recovery and or self-defined wellness, so patient-centered. Harm reduction, a harm reduction-oriented principle to OUD care involves acknowledging and supporting of any steps taken by individuals to improve their health and well-being, and respecting individuals' decision and goals concerning substance use and providing and promoting strategies to minimize opioid-related harms. Integrated continuum of care. Opioid use disorder is understood to be a chronic, relapsing, and remitting conditions. The guideline also supports the use of a stepped and integrated approach where treatment options are continually being adjusted to meet the changing needs of the individual, circumstances, and goals of people receiving care. Comprehensive health management. Opioid use disorder should be managed within a broader framework of comprehensive health care and support, including routine and ongoing medical, mental health, and psychosocial assessments. And finally, family and social circle involvement in care. Family and social circle involvement in treatment planning and decision-making should be encouraged whenever possible and when deemed appropriate by the individual and their care team. So very patient-centered. I'll go through guideline recommendations. This is basically the next few slides. Next slide, please. It's an overview of 2023 OUD guideline recommendations. There are 13 recommendations in total, divided into pharmacological treatment, non-pharmacological treatment, and harm reduction categories. What I'll do is the next slides will go through details of each recommendation. So what we used was quality of evidence using the grade scoring, which means initial estimates of quality are based on the traditional hierarchy of evidence, whereby meta-analysis of randomized clinical trials are assigned the highest score, which we're used to, followed by individual clinical trials, quasi or non-randomized trials, observational studies and reports, and expert opinion, which is assigned the lowest score. So the strength of recommendation within these guidelines is uses the grade system, which takes into account the quality of evidence as well as additional factors such as clinician, patient, and policymakers' values and preferences, cost effectiveness, risk-benefit ratios, and feasibility. So this list of recommendations has been significantly modified since the 2017 guidelines, and I'll highlight the recommendations that are new additions as we go through the slides. And reminder, this is recorded and you will have the deck of slides. So recommendations, adults with OUD should be offered OUD as standard of care. This is a new recommendation. The quality of evidence is high. The strength of recommendation is strong. There's multiple systematic reviews demonstrating OAT's effectiveness of sustaining treatment retention, reducing unregulated opioid use, and minimizing risk of morbidity and mortality. So next slide. Recommendation number 2, prescribers should work with each patient to determine which of the following OAT medications, buprenorphine, naloxone, methadone, slow-release, or morphine, is most appropriate based on the patient's circumstances, goals, and previous treatment experiences. This is a new recommendation, novel. So there's no longer first line, second line, or third line. The quality of evidence for buprenorphine and methadone is high. The quality of evidence for SROM is moderate, and the strength of recommendation is strong. The guidelines, again, has moved away from ranking the order of oral OAT medications as first line, second line, and third line options. So this guideline, as you read through it, recommends that clinicians discuss the risks and benefits of all 3 OAT medications with people receiving care and collaborate to choose a medication that is best for each individual based on their preference, treatment history, and other individual circumstances. So again, very patient-centered. The update is not intended to equate OAT medications in terms of safety and efficacy evidence. The evidence on the safety and efficacy of SROM is limited in comparison to buprenorphine, naloxone, and methadone. So the intention is to offer patients a full range of available options and facilitate the collaboration, the patient-centered care approach to treatment selection. So in essence, this is a very key departure from the initial guidelines, which recommended first line, second line, and third line options. Recommendation 3. Transition between OAT medications should be facilitated if indicated by clinical circumstances or patient preference. This is also a new recommendation. The initial recommendation did not include recommendations concerning transitioning between OAT medications. The quality of evidence is low, but the strength of recommendation is high. The reasons for wanting to transition can include, but not limited to, inadequate management of cravings or withdrawal, fewer side effects, increased flexibility, and possibility for transition to extended release buprenorphine, the injection. The risks and benefits of transitioning between OAT medications should be weighed carefully and a discussion with the patient. Pharmacological treatment recommendation 4. So this is also a new recommendation. Patients stable on 8 milligrams to 24 milligrams of sublingual buprenorphine naloxone may be offered the monthly extended release formulation or Suboxone, Sublocade, if indicated by patient preference or circumstances. So this is an injection formulation that was not available in the 2017 guidelines. The quality of evidence is low due to the relative newness or novelty of this option, and the strength of recommendation is strong. Extended release formulation of buprenorphine is administered monthly via abdominal subcutaneous injection. It might be preferable to enhance convenience and flexibility and also to reduce medication burden, and also a consideration in a lot of the rural and remote community whereby there's a limit of the number of pharmacies located around. Pharmacological treatment recommendation 5. Injectable OAT with diacetylmorphine, which is heroin, or hydromorphone should be considered for adults with severe OUD and ongoing unregulated injection opioid use who have not benefited from or even declined oral options for OAT. Then this is a new recommendation. It was added to emphasize the role of injectable OAT as a vital component of more of a comprehensive and integrated approach and continuum of OUD care. The 2017 guideline did not include information on IOAT, injectable OAT. This option was presented in a dedicated IOAT guidance document for individuals who have not benefited from oral OAT options at that time. The quality of evidence is moderate. The strength of recommendation is weak and conditional depending on the individual. So both diacetylmorphine and hydromorphone may be considered. A selection is made based on availability, individual preference, and prescriber judgment. Injectable opioid agonist treatment can be provided alone or even co-prescribed with an oral OAT, although buprenorphine naloxone is generally not co-prescribed with IOAT. And we did go over this somewhat within some of the BCPHA's training too modules. Recommendation number 6. Opioid agonist treatment should be viewed as an open-ended treatment. However, if a patient wishes to discontinue medication following a sustained period of stability on OAT, usually it's about 12 months or longer, a slow taper should be offered because it's dependent on a patient's goal. This is an updated recommendation. The quality of evidence is moderate. The strength of recommendation is strong. So individuals who express a wish to discontinue treatment should be advised to consider a gradual taper schedule. It should be emphasized that discontinuing OAT is not recommended, but individuals who discontinue OAT, it's because they're at an increased risk of return to unregulated opioid and related harms. Number 7, for adults who choose to discontinue OAT, a relapse prevention plan should be collaboratively developed and implemented after discussion of both a pharmacological and non-pharmacological options. This is a new recommendation. The quality of evidence is low, strength of recommendation is strong, and really pharmacological strategies may include prescribing as needed buprenorphine naloxone, a small supply to facilitate reinduction if needed, and offering PO or oral naltrexone as a maintenance treatment. Non-pharmacological relapse prevention measures might include psychosocial treatment interventions and community-based supports and programs. Individuals should be informed that both oral naltrexone and psychosocial interventions have limited effectiveness as standalone treatment strategies. So close monitoring and other relapse prevention approaches, such as the PRN naloxone, like what I just said, should be considered in addition to other selected relapse prevention approaches. Recommendation number 8, oral naltrexone is not recommended treatment for adults with OUD, but however, it might be offered to individuals who have declined or discontinued OAT and would prefer a non-opioid treatment. This is an updated recommendation. Quality of evidence is low. The strength of recommendation is weak and conditional, but again, might be considered in the context of an overall strategy to prevent a return to unregulated opioid use after a discussion of different available options. So this is at least a tool if needed. Recommendation number 9, while extended, like what I mentioned, well, this is an extended release naltrexone. It's not currently available in Canada. It is an evidence based up treatment that might be considered for patients with OUD who are not interested in OAT. It is available in the States. This is a new recommendation. The quality of evidence is moderate. The strength of recommendation is weak, and available research has shown that extended release naltrexone is superior actually to placebo for treatment retention, cessation, or stopping opioid use and reducing cravings. It might be a suitable option when other OAT medications are not appropriate. So I'll go now to talking about non-pharmacological treatments, starting off with the recommendation number 10. Withdrawal management alone, including rapid opioid agonist tapers without transition to OAT, is not recommended. This is updated. Quality of evidence is moderate, and the strength of recommendation is strong. The majority of people who actually undergo withdrawal management alone return to use soon after the treatment completion. So there are risks associated with return to use, which include drug poisoning due to lower tolerance and risk of acquiring bloodborne infections if using non-sterile equipment. Individuals who request withdrawal management alone should be provided with clear, concise information about risks and be engaged in supportive, constructive, and discussion about safer treatment options. So good discussion is really important for individuals that wish to go towards withdrawal management alone. If the patient chooses to pursue withdrawal management, this should be conducted in an outpatient setting, followed by collaboratively developing a relapse prevention plan and referral to a long-term psychosocial treatment and support. This is updated. Quality of evidence is moderate, strength of recommendation is strong. So outpatient withdrawal management programs permit a slower, more flexible and individualized approach to tapered agonist reduction compared to inpatient withdrawal management. So individuals undergoing withdrawal management should be offered referral to psychosocial treatment interventions and community-led supports. Psychosocial treatment interventions and supports should be routinely offered to adults with OUD in conjunction with pharmacological treatments. This is also updated, and quality of evidence is moderate, strength of recommendation is strong, and you can read more about this within the guidelines. As a standard of care, individuals should be offered access to psychosocial treatment and supports as part of the OUD care plan. So an individual's decision not to participate in psychosocial treatment intervention should never preclude or even delay provision of evidence-based pharmacological treatments. Harm reduction. Conversations about safer drug use, take-home naloxone, and referral to other harm reduction services should be routinely offered as part of standard of care for individuals with opioid use disorder. This is also updated. Quality is moderate, strength is strong. Clinicians should always routinely, especially in pharmacies, offer information and education about harm reduction resources and safer use practices when appropriate. The guideline includes a range of harm reduction services, including safer consumption supply distribution programs, the take-home naloxone programs, overdose prevention sites, supervised consumption sites, and drug checking services. So drugs or checking services have demonstrated their utility in monitoring the composition of unregulated drugs, in addition to reducing the risk of harm to individuals who use opioids. So I'll go through now the clinical guidelines, and this has been out for a couple of months now, and many of you might have seen some of the clinical guidance already out in practice. This is significant change. In the updated guideline, the maximum daily dose of buprenorphine naloxone was raised from 24 milligrams to 32 milligrams. A daily dose of up to 32 milligrams may be reasonable right now and can be provided safely to address the high opioid tolerance of people who use fentanyl now. The day one maximum dose for traditional induction is 16 milligrams now, but higher doses can be used if withdrawal symptoms are persist at the 16 milligram mark, simply because of the high tolerance that some people who use fentanyl are at. Low dose induction, we used to refer this as microdosing induction or micro induction, is induction method that slowly up titrates a small amount of buprenorphine naloxone without stopping all other opioids until a therapeutic dose has been reached. This might be a preferred induction method for people currently using fentanyl or other intermediate or long-acting opioids. This is an example of a low induction or microdose induction of buprenorphine naloxone. This is a sample 7-day protocol. That there is an 8-day example protocol in the guideline. It really depends on the individuals. In the guideline itself, there was a consistent twice-a-day dosing induction. So benefits of low-dose induction, I'll just review it. It doesn't require a period of withdrawal. It might reduce the risk of precipitated withdrawal, and it can be started at home or in the clinic. It can also be co-prescribed with a full agonist to reduce reliance on the unregulated drug supply during the induction. So you might see an individual on methadone or other full agonists while you are looking at a low induction with a buprenorphine naloxone. So it varies, right? You've probably seen a lot of different variations. It varies with prescribers, varies with teams. It often will require splitting the dose of the tablets. Keep any partial tablets for the next dose, just because it can result in uneven dosing. So induction protocols can be dispensed in the compliance blister packing to reduce confusion in the take-home dosing regimen. And these are really small when you cut them. During splitting tablets, any known or partial lost pearls just recorded accordingly to our record keeping at the pharmacy level. Also, missed dose protocols with the prescriber. It's so important to have that discussion proactively with the prescriber, how to advise and what to do if the patient misses during the induction week. So what if the patient or client takes day 1, 2, and misses 3? Like, what do you do on day 4? So PPP 66 states right now to cancel RX after 4 missed doses of buprenorphine naloxone, but induction protocol involves increased doses per day. So have that proactive discussion with the clinic teams. So what do you do, right? Collaborate closely with the prescriber and the team and share treatment outcomes. Since this protocol is still relatively new in a way, communicate. It's really important to communicate and also communicate with the patient on possible precipitated withdrawal symptoms and how to manage it. Although, there is less likely to get precipitated withdrawal compared to traditional induction protocols. There's still a possibility. Other support resources include Care Connect that you can go on to look at records, and also the 24/7 addictions line. So next slide. Traditional induction, preventing precipitated withdrawal, Traditional induction is really, there needs to be an adequate time since the last opioid use to prevent the precipitated withdrawal. So greater than 12 hours for short acting, such as heroin, oxycodone, or hydromorphone. Greater than 24 hours for immediate acting opioids, the slow release or morphine, and also confirmed or suspected fentanyl, and 48 to 72 hours for long-acting opioids such as methadone. So to prevent this, you have to look at adequate time since the last opioid to prevent the precipitated withdrawal. Traditional induction, how you manage things, it can occur when the first dose of the partial opioid agonist, such as buprenorphine naloxone, is administered to a person who's been using full agonists before they've achieved a moderate stage of opioid withdrawal. So I'll go through this slowly. There are two options right now for managing precipitated withdrawal, and delay induction and high dose buprenorphine naloxone. So delay is option 2, and then the high dose is option 4. So those are new. Option 1, if a person was going through precipitated withdrawal, is to continue the induction, administer additional doses, the smaller doses of 2 milligrams every 1 to 2 hours until the withdrawal symptoms are resolved. Option 1 also includes informing the patient that any additional doses of buprenorphine naloxone can initially worsen the withdrawal symptoms before the improvement. So talk to the patient. Offer non-opioid adjuncts or symptom management, and that includes, the clonidine, and then the PRN, anti-nauseants, antidiarrheals, NSAIDs, acetaminophen. Option 2, this is new, is delay the induction. If the person chooses to continue, perhaps consider waiting a few hours to allow that full agonist to clear the receptors before administering the next buprenorphine naloxone dose. Offer the non-opioid adjuncts, what I mentioned, to treat the withdrawal symptoms as needed, and continue to day 1 maximum or until withdrawal symptoms are resolved. Option 3, stop the induction. Provide reassurance that symptoms will resolve as the buprenorphine dissociates from the receptors and the full agonist can resume its activity. Offer non-opioid adjuncts or shorter acting full opioid agonists to treat the withdrawal symptoms as needed, and discuss a plan for future induction. It's not a race. Let's just look at that a little bit later on if you want to start this again as an example. Option 4 is to go forward with a high dose buprenorphine naloxone. This is new. Involves treating the precipitated withdrawal with additional doses of buprenorphine naloxone in close succession. So typically you would add like an 8 milligram to 24 in total. And again, this is option number 2, and option number 4 is relatively new in this guideline. Missed doses. There's different protocols for missed doses. When you read the guidelines a little bit more closely, and we're talking about number of consecutive missed once daily doses. So for missed doses with the return to full agonist opioid use, there are considerations for individuals who want to resume buprenorphine naloxone. If a person misses 1 to 3 consecutive once daily missed doses with return to full agonist use, there's no change. No change is required at all. It's likely safe to continue the buprenorphine naloxone without reinduction. 4 consecutive once daily missed doses with return to full opioid agonist use, clinicians should discuss the risk, and pharmacists as well, precipitated withdrawal with the patients and weigh against the benefits of continuing buprenorphine naloxone. For patients who prefer to continue, a test dose could be managed and planned for precipitated withdrawal. And we went through augmented therapy that can be used for helping the precipitated withdrawal. 5 or consecutive once missed daily missed doses will return to full agonist use. A new induction might be required, and then you would go back and follow the low dose or traditional induction protocols. So PPP 66, as a reminder, the buprenorphine naloxone policy guide, the dispensing pharmacy is required to cancel the prescription if the individual misses 4 or more consecutive doses of buprenorphine naloxone and notify the prescribing clinician. So day 5 means they cannot get a dose if it was a return to full agonist. So for missed doses without return to full agonist use, so 5 or fewer consecutive once daily missed doses without return to full agonist use, there's no change in dose required, and you can resume the previous dose without a dose reduction. If there are 6 or more consecutive once daily missed doses without full return to full agonist use, should be held pending in-person or virtual assessment, and the remainder of the prescription should be canceled. And reasons for missed doses should be discussed, documented, and in the clinical visits subsequently, with attention to supporting the patient for better OAT retention. We're really looking at retention, and retitration might be required and really tailored. So just note right now, the magic number to remember is always 4 right now. The PPP 66 does say cancel after 4. The college is reviewing PPP 66 for alignment right now. So just remember, follow the PPP 66 of 4 consecutive once daily missed doses for a cancellation. Extended release buprenorphine. So this is the injectable Sublocade. And this is a new addition. Like I said, the formulation was available after the release of the 2017 guideline. And it's administered monthly via abdominal. Remember, it's abdominal, and remember, it's subcutaneous injection. So individuals should generally be inducted and stabilized on sublingual buprenorphine naloxone for a minimum of at least 7 days. This is in the product monograph prior to receiving the extended release buprenorphine. There is actually emergent evidence that supports the feasibility of perhaps more of a rapid transition to this product, which may facilitate a better treatment retention. Individuals generally, just as a reminder, they start extended release buprenorphine at the 300 milligram mark for the first 2 months, and followed by a maintenance dose of 100 milligrams from month number 3. At the discretion of the prescriber, the treating prescriber, the maintenance dose might be increased to 300 milligrams if the patient experiences ongoing opioid cravings or ongoing unregulated opioid use. So individuals who have been stabilized on about 8 to 18 milligrams of Suboxone or buprenorphine naloxone can transition to 100 milligrams of maintenance after a single 300 milligram dose. And again, administered monthly, minimum of at least 26 days, required between doses when you put it on, when you enter it. Just remember, it's at minimum length of 26 days on your computer system to go through PharmaCare. And there's procedures for ordering things as a separate than the standard procedures. Missed dose protocol extended release, it's up to a 2-week delay, could receive the next dose, because when you look at kinetic wise, you do have buprenorphine in the system for at least 40 something days. So next dose as soon as possible, monthly injections can be resumed thereafter. If there's more than a 2-week delay though, reinduction might be warranted, and the individual can be restarted on sublingual buprenorphine naloxone, followed by transition to extended release again. So that's there for you as this is a newer product since the 2017 guidelines. We're going to shift gears to methadone. So this has changed slightly again. We're really looking for adjusting the methadone to allow higher starting doses for patients with that higher opioid tolerance, the individuals that are using fentanyl or its analogs. So starting dose will depend on multiple factors when you look at the patient, the individual's known opioid tolerance, their current opioid use, and also concurring substance use patterns. So starting doses, you can see that there's 4 different rows there. So number 1, for those with low or no tolerance, the starting dose low at 5 to 10 milligrams. For those with unknown or moderate use known tolerance, suggested starting dose is about 10 to 20. High tolerance is 20 to 30. And for those with very high tolerance, the suggested starting dose is 30 to 40. And guideline endorses a starting dose of up to 40 milligrams for individuals who use fentanyl and have had previous experience with methadone. There's still a lot more research going on with this, simply because there's a lot of people with high tolerance right now, and we need more evidence on whether or not starting at a higher dose is needed. This is a difference too. People with established high opioid tolerance, so any documented history of fentanyl use and experience with methadone, doses are titrated faster, maximum about 15 milligrams every 3 days. So you'll see this, and you probably have seen this. So once the daily dose reaches approximately 85 milligrams, titration process can be slowed down or should be slowed down to a maximum of about 10 milligrams every 3 to 5 days. You will see that sometimes the scripts don't end in 3 to 5 days, or they don't end every 3 days, but there's a bigger script, a longer script that you're given, and the client or patient has been encouraged to go back for increased titration if needed, and you can help support that as a pharmacist as well. So for people with lower unknown tolerance and no active fentanyl use, or have had no history of OAT with methadone, doses are increased more cautiously, obviously, around 5 to 10 milligrams every 3 to 5 days. And stabilization really depends on that individual, right? The optimal therapeutic dose varies quite a bit. You will see a different range with your clients and patients as well. Previously, there was mentioned that it ranges from 60 to 120 milligrams, but when you look at current clinical evidence and experience, it suggests that that doses of 150 milligrams or higher may be required to meet those therapeutic goals. Simply because there's a lot of fentanyl tolerance that we see out there right now. So I'm going to change gears to slow release oral morphine, and I'm talking about Kadian right now. So again, suggesting higher SRAM doses, starting doses for patients with higher opioid tolerance, and you've seen this. This is just in the guidelines now. Starting dose ranges can range from 50 to 300 milligrams. And again, you see the same thing, the 4 different rows there, going from low to no tolerance is 50 milligrams, unknown or moderate known tolerance, 100 milligrams to 150 milligrams. And for those with known high tolerance, you're really starting at 200 milligrams, and very high tolerance at 300 milligrams. And again, higher doses may be considered with caution on a case-by-case assessment of risks and benefits. If needed, should higher doses are considered, and it should be documented. So please read these doses really carefully, and sometimes misreading can happen just because there might be some individuals are at the lower no tolerance and they're just starting, and there's errors made reading it as 500 milligrams versus 50 milligrams. So please, please, please do read those scripts really carefully and talk to your patients to ensure that we're error-proofing the situation too. Again, dosing and titration, we're really looking at a little bit more rapid increases. And again, you will see scripts that are written pretty much for a long period of time, but encourage the patient, the client, to go back to have this reassessed. So dose increases can go up 100 milligrams every 24 to 48 hours. There's really no defined maximum dose for SRAM. And this is a key change too. So remember, buprenorphine naloxone was 32 milligrams. This one is a key change for a slow release oral morphine, where you don't need to sprinkle. The default is to provide SRAM as a capsule for the person to swallow whole. And if needed, remember, patient-centered care is, if needed, sometimes some patients do want sprinkling. And if clinically indicated or preferred, the capsule can be opened and the pellets can be sprinkled into a cup for swallowing. Missed dose protocol. Remember, I mentioned the magic number is 4. So alignment. So missed dose protocol for methadone and SRAM is on this chart for you. The guideline has modified missed dose protocols to really look at alignment. The dispensing pharmacy is required to cancel the prescription if the patient misses 4 or more consecutive once daily doses of both methadone and SRAM doses, and notify the prescribing clinician. So the new protocol, you can look at this a little bit more, where when it's 1 to 3 consecutive once daily missed doses, really no action, no dose adjustment. If it's 4 once daily missed doses, is assessing, can assess at the 50% mark, and also for both of them. And 5 or more is really cancel the prescription and reassess, right? You have to restart the titration. But in reality, when we're looking at our workflows, we have to notify the prescriber and the prescriber team every time there's a missed dose. So there's something wrong when an individual misses certain doses. Split dosing is using, there you might have some people that are doing split dosing, and you can count fully missed doses, missed days, rather than missed doses to conduct that assessment. And you would obviously be in connection with the prescriber team. What's very different also is take-home dosing. Buprenorphine naloxone, take-home dosing considered immediately, including during induction. That's why you have home inductions where clinically indicated, who meet certain criteria, such as a clinical psychosocial stability. So generally, you're looking at ability to attend appointments, absence of unstable psychiatric comorbidities, such as psychosis or thinking of suicide, absence of severe behavioral issues at different places, absence of severe sedation, absence of high risk of uncontrolled substance use patterns that cause frequent overdoses or blackouts. An ability to store medications, access to secure lockbox or cabinet is totally fine. Can be initially prescribed, and you've seen this most likely on a 1 to 2 week supply, to just establish the effectiveness of the dose, and then longer prescription intervals might be appropriate once there's a stable dose has been established. And also, people who experience homelessness can still be considered for take-home dosing, and people who continue to use substances can be considered for take-home dosing as well. So those are the key changes. There's also alignment to take-home dosing criteria for both methadone and SRAM. Again, the same thing. Total cessation or stopping non-prescribed substance use is not required. And we're looking at take-home methadone and SRAM doses should be started as individual non-consecutive doses for individuals who meet the take-home dosing criteria. So you're talking about, maybe a Monday, Wednesday, Friday. You might look at twice a week take home, perhaps weekends. So very gradually, additional take home doses can be offered gradually every 2 weeks to individuals who, again, can consistently manage the previous take home doses, sustain the adherence, and really experiencing improving clinical and psychosocial stability. And there is a clinical discretion that might dictate faster take-home dosing schedules, depending on where the individual is located, maybe rural regions, pharmacy hours, success with home doses, and perhaps there's work that needs to be considered. This is just a general slide on take-home dosing for methadone and SRAM. So not a candidate for some of those items I already mentioned. If you go to the next slide, it provides a greater summary of take-home dosing for 1 to 3 non-consecutive take-home dosing, ability to keep appointments, no acute behavioral psychiatric issues, no high-risk or uncontrolled substance use patterns, which I mentioned before with the buprenorphine naloxone. And 4 to 6 consecutive take-home dosing is rare missed appointments, minimum non-prescribed substance use. So that's available for you to look at in a slide versus reading through the guidelines. Okay, next slide. The other thing that you can read more about is the urine drug testing. And there's really no minimum number required UDT or urine drug testing for people on OAT. Pharmacists can check CareConnect for UDT results as well. Negative UDT for other substances is not a requirement for take-home, for consideration for take-home dosing, and also should be performed when results might impact the treatment plan, should not ever be used punitively. and should be scheduled, not surprised, right? And witness UDT should never be used. And the purpose should be discussed with the individuals, and including how unexpected results will be addressed. So this is really important and quite a change. So the updated clinical guidance, when you look at it on our website, the BCCSU website, there's a continuing care appendix about concurrent mental health concerns. There's also on ongoing substance use, acute and inpatient considerations. There's topics on chronic pain, long-term effects of OAT tapering, and opiate agonist treatment and driving. There's also a discussion about the emergency department buprenorphine naloxone induction. There's guidance on this initiation in emergency departments. There's also more of a fulsome look and discussion and inclusion of specific populations. Guidance for a specific population, including Indigenous peoples, 2S LGBTQ plus populations, pregnant individuals, youth, older adults, and a focus a little bit more on rural and remote communities. So have a look at that as a resource as you go through the different changes. So really significant changes in the guidelines compared to about 6 years ago. So key guidelines is, remember the little fan that we had at the very beginning, is focus on the person-centered approach, really focus on the person-centered approach. And there's really no first line, second line, third line, right? We're moving away from that ranking. There's the modified maximum starting doses that we had that discussion with. You saw the differences buprenorphine naloxone. Also, there was a maximum dose of at least 32 there, modified starting doses with a different 4 rows there. Low dose induction guidelines for buprenorphine naloxone is there, which we last termed it as microdosing. There's guidelines on the provision of the SUBLOCADE or monthly extended release buprenorphine. Simplified guidance for addressing missed doses. So just remember the magic number is 4 right now to make it a lot easier for all of us to remember. Also less restrictive protocols providing to take-home doses. We went through also the UDT and really take some time to look through items. This deck of summary slides is available for you a bit later on as well. So I'll pass on to Anne, who will be talking a little bit more and wrapping up the slides while I look through questions as well.
Thanks, Mona. Okay, I'm just going to chat a little bit about the regs here, the college policy, professional practice policy, PPP 66 for OAT. So in order to align with the updated provincial guidelines, last year in November 2023, the College of Pharmacists, their board approved amendments to PPP 66 OAT. And I'm just, like I mentioned, going to highlight the main changes to those policies. So first of all, the main PPP 66 OAT, the wording was updated to reflect the current compounding criteria for methadone. So in other words, compounded methadone is the last resort option for patients who have not benefited from documented reasonable trials of at least 2 commercially available methadone formulations. For example, they've tried methadose cherry or methadone D unflavored, and for whom methadone remains the optimal OAT option, or during a period of shortage or no supply of a commercially available methadone oral preparation. So this compounded methadone as a last resort, it hasn't changed since it was first implemented in 2020. PPP 66 was just updated now to include that. However, it has also been updated, requiring pharmacies providing MMT services to maintain the most recent version of the Health Canada policy on manufacturing and compounding drug products. So that's a required pharmacy reference material. Just a note about compounded methadone. This must be ordered from the product distribution center. So this is the central source that has been approved for compounded methadone at this time. There is no provision for individual community pharmacies to compound the methadone for maintenance treatment currently. And so there's a couple of links there, and it will be available on the slides in finding more information in how to order and dispense the compounded methadone. Okay, next slide. Thank you. So, okay, so when we're looking at the policy guides, basically the wording there, the language has been updated to align again with the provincial recommendations that OAT choice is an individually tailored process. So it's a collaborative decision process with the client, like Mona had discussed. Clinicians should discuss the risks and benefits of all three OAT options with patients and taking a patient-centered approach. So it removes the first, second, and third line treatment options, and instead, together, the client, the clinician, they select a medication that aligns with the patient's goals, treatment history, and other individual circumstances. When we look at the policy guides individually, with SROM, it's been updated. The main change here is that they've removed the requirement for the specific words for OAT in the directions for use section on the CPP, the Controlled Prescription Program form. Because with the harmonized CPP, there's already, of course, that middle section, the pink section that must be completed for OAT medications. So, so prescribers no need to put for OAT in the directions for use section. As well as Mona mentioned, SROM capsules can be provided whole to be swallowed in witness ingestion. So if there is no instructions for DWI on the prescription, the default is that you can provide it and witness it as a whole capsule, that first dose. Alternatively, the patient and or the prescriber can request for the capsule to be opened and pellets sprinkled into the cup for immediate ingestion. The policy guide for PPP 66 methadone wording has just been updated to include the compounded methadone as a last resort option, or when there is a shortage or no supply of commercially available methadone formulations. And then again, in all the policy guides, they've changed the missed dose principle. It's been updated to reflect the OED guidelines. So if a patient misses, like Mona mentioned, the magic number 4 or more consecutive days, the prescription must be cancelled and the prescriber notified. Again, the college is aware that for buprenorphine and naloxone, there is this discrepancy between this policy guide and what BCCSU OED guidelines state, depending on whether the patient has returned to full opioid agonist use or not during those missed days. The college are looking into it, and and they may be updating the policy guide to reflect this difference. However, as Mona mentioned, must follow the current approved policy guide, and so do cancel their prescription after 4 or more consecutive days of missed doses for buprenorphine and naloxone. And you want to highlight this is consecutive once daily missed doses. So it's based on the number of days and not doses. So if a client was taking a methadone dose that was split dosing, like an AM and PM, you would count the fully missed days rather than the doses. Other changes were just housekeeping and updated language to reflect current practices. But do note that the methadone maintenance expectation form, that appendix in the MMT policy guide, has now been removed. Next slide, thank you. No changes here. For time, I'm going to skip this slide. Just remember, you have your regular benefits, your partial benefits, and your non-benefits. It's all listed there, but let's go on to the next slide. Yes, so PharmaCare Plan is Z. Okay, so this came about last June 2023. Plan is Z is 100% coverage plan. So it fully covers OAT for BC residents enrolled in MSP. Just want to make a note about exceptional plan is Z. So this is exceptional plan is Z coverage is available to people living in BC who are not yet fully enrolled in MSP. So this ensures that they can continue to get their OAT while they wait for processing of their MSP application. So this includes people living in BC who have not yet applied for MSP or have applied for MSP but have not yet presented their ID at an ICBC counter, or they've applied but they're just in the MSP coverage wait period. And pharmacists and other practitioners can initiate exceptional plan AZ coverage. So you can fax the application form to HIBC for their review, or you can phone HIBC help desk. You just provide your college ID and the patient details. HIBC will review the details, and if the patient meets the criteria, then special authority enters 6 months of coverage into PharmNet, and they will inform your pharmacy by fax with the coverage dates. So a reminder, SROM, Cadian specifically, and methadone, whether it's commercial or compounded methadone, pharmacies are to use the PINs for OAT claims only. If the prescription is for pain, then you use the DIN. So do not use the OAT PINs for pain indications. Yeah. Buprenorphine formulations, you do use the DINs. And so because you are using the pins in PharmaNet when dispensing methadone and Cadian for OAT, it will not automatically be captured in PharmaNet's drug evaluation feature. And so drug-drug interactions may be missed. So just be extra vigilant, especially with the risk of co-prescribed methadone and naltrexone. Also, sorry, one more point about the pins. Just make sure you use the correct types of pins for OATs, depending if there's direct interaction or not, or if you are delivering the medication to the patient's location or not. So you have the 4 pins, you know, for witness ingestion, the no direct interaction, which is for take-home doses or carriers, the direct interaction with delivery. So you're delivering the medication to the patient's location and you're witnessing the ingestion. And the 4th one is the no direct interaction with delivery. So you're delivering the medication to the patient's location with no witness ingestion. And so just a word that if you are dispensing a patient-specific OAT medication to a nurse at a treatment facility, and it's the nurse that is witnessing the ingestion, you would use the PIN for without direct interaction because it's the nurse who will be witnessing that. And one last point about the pins is that just remember that the different pins for the same medication will not trigger duplication in PharmNet. So again, really important to review PharmNet profile very carefully, and also to check for TMU entries. These are entries made by clinicians at outpatient health facilities. They can enter entries for OAT in PharmNet through the TMUs. So again, you may see different pins for the same medication in the patient's profile entered by clinicians as well as other pharmacies as well. Okay, next slide. Thank you. So the BCPHA OAT Compliance and Management Program for pharmacists and pharmacy technicians, it is currently being updated to reflect all these changes. And those who have continued access or have completed it will see the latest version, we hope, within the next couple of months. And somebody did also ask about a training resource for Supplicade on administration or extended release buprenorphine injection. BCCU has created a video on this, and so it's coming out. So do stay tuned for that. And then over to you, Mona. Thank you.
Hi. Sorry, just reading through, but it's going very fast. I'm just checking time. Okay, so we're going to go through the different cases, and here's case number 1, missed methadone doses. So a client has been coming to your pharmacy for about a year, has recently transitioned from buprenorphine naloxone to methadose, stable on 130 milligrams of methadone, does not have prescribed take-home doses, comes in on Tuesday for her methadone dose, does not come back in until the following Sunday. So what should you be doing? What's going through your thoughts? And you can type through items as well. Are we putting this in the chat, Anne?
Sorry. Yes, they have asked prescriptions cancelled, but that's it. Prescriptions cancelled, yes.
Prescriptions cancelled, yes. So go to the next slide. This is like our training session.
Yes, yeah.
Yeah, you can go to the next slide. So this is a summary. It's just something for thinking. Like I know that there's a lot of different questions on the Q&A as well. So we'll go through some of this. This is available for you. So 4 days missed, pharmacists should cancel, encourage to see prescriber, missing 4 consecutive doses, it's there really. And then 5 days is there for you. So next slide. So take-home doses. So number of days per week of daily doses there. Slow release oral morphine, 1,000 milligrams once daily by mouth. Provide capsule to be swallowed whole. Daily witness ingestion Sunday to Friday. Take-home dose Saturday. Dispense take-home on Friday. So what this is really saying, is generally you can start as a single take-home dose per week. So if you go to the next slide, so it's been aligned. Number of take-home doses increase gradually, 1 to 2 weeks. You can look at that, starting with progressing through the 1 to 3 non-consecutive, like I said, either like a Monday or Monday, Wednesday, Friday, and then it progresses to 4 to 6 consecutive doses. And you might see this a little bit faster, depending on the situation. So I'll go to case 3, initiating the extended release buprenorphine. A client at your pharmacy is completing a traditional induction on sublingual, stabilized on the 24/6 buprenorphine naloxone, stable for at least 3 days, receive a prescription from her physician for the client to start extended release after the client has been stabilized for 7 days on this current therapy. So what steps must be taken before you can dispense and administer extended release buprenorphine? So a lot of things to consider if you go to the next slide is ordering the product, right? There's an online form. If any of you have issues with this, you can connect to open up an account. And then storing is really important within the refrigerator and the cold chain, and creating a plan in advance of that date. We can also inject the buprenorphine injection too. So really plan out what you have in the fridge. Like for example, today, the same, we looked in the fridge, we probably need to order a bit more if needed for certain appointments that might be forthcoming. And just remember that this has to be delivered to a clinic or picked up by a nurse or prescriber. We cannot give it straight to the patient or client to bring it to a clinic if they are choosing to have that injected at a clinic site.
So Mona, there was a question here around like the maximum dose of Suboxone 32 milligrams. And so before transitioning from Suboxone to Sublocade, so at the moment it says Suboxone, the patient has to be stabilized between 8 and 24 milligrams. So what do you do if a patient's on 32 milligrams?
You can still transition them. Depending on what the patient wants. We have one individual right now, he's at 32. He did the micro or low dose induction, pretty standard. He's actually at 24/32, then he will be transitioning in a few more days to an extended release. So it really depends on the individual. You could dial it back depending on the comfort level of that individual.
Okay, thanks.
So really creating a plan is so important for that. And again, there were people, if you go to the next slide, individuals are wondering about the administration. Like Anne said, there will be a release, I think, in 2 days or so of a course. It'll go through everything, like everything you've learned about. We try to mimic what was taught in injection training too. And make sure you have that extended release in stock. If not, ask around the neighborhood just in case. It is a lot easier getting the product now. And then and talk over with the client, talk over with the prescriber. If you are doing this in terms of missed doses, what are you doing to communicate back to the clinic? Because that's really important in terms of understanding the whole care for that patient. Is there anything else to add, Anne?
Well, there was one that says specifically about what training does a pharmacist need to have to inject Sublocade?
It's really about your knowledge, skills, and abilities. If you are comfortable with looking at what we provide in terms of understanding from the product itself, because there's little things that are a little bit different with the product where it feels like an oil-based solution. So, and then the angle and all that. So you could look at that to get more comfortable with items with that item to inject. Some people want to shadow somebody just to get more comfortable with that particular injection, and that's available for you too. The most important thing is if you have the knowledge, skills, and abilities, is what our college says before you
Mm-hmm.
do this injection.
Great.
Okay. I think the next slide will provide some resources for you. There's a series of resources you can look at. The team has done a really great job at searching on the website as well. And those are specific resources that's available for you, and you can look at those links and bookmark it if it's easier for you. Other resources examples include the handouts, the principles of care. You can print it out and put it on the wall if you want for the next slide. So that's available too for you on the different pages to make it easier to locate information compared to before where it was just a straight booklet. And also there's new interactive resources that the team did for mobile devices, really easy now. Because remember, many years ago, there was not many mobile devices when a lot of things started. Think we're almost at time, but we'll take a look at the questions then.
Yes, I'm trying to go through some of the questions, but there are a lot of really great questions, and we are going to compile them, and we will share these questions QAs as well. Let's talk about first of all, I know there's a lot of questions around safer supplies. Why is not dilaudid not on there? Why is it not covered? But I know the focus for the maybe actually you can discuss a little bit about why safe prescribed alternatives aren't in the OUD guidelines.
Yeah, prescribed alternatives is a different set of items that we'll be looking at, and this is really a focus on the opiate agonist therapy. There's a relook at different things that are available for the prescribed safer alternatives at a later state too.
Okay. Thank you. Let's talk about a little bit about take-home doses. I know with methadone, there's more flexibility around that. We did have a comment from a pharmacist that they had 30-day carry for methadone, packed in individual bottles for travel reasons. Are there any restrictions on the number of carries?
There really isn't, depending on where that person is located. Perhaps maybe they are working. I know there's a lot of border towns that people are working more rural too. So lots of things to consider, and then talk over with the clinician team what the plan is, because that's important to know, because we often don't have access to the files.
Okay. A couple of questions around naltrexone. So that is now one of the recommendations. I think it is covered for alcohol use disorder under pharmacare. Is it covered for the treatment of opioid use disorder?
I have to look at that. I'm
Okay.
sure.
Yeah. Wow, there's a lot of questions around prescribed alternatives. A couple of people have asked about fentanyl patches as well, because they've seeing a lot of that. I've provided a link to the fentanyl patch protocol. Is there anything you want to discuss specifically about that?
No, just the fentanyl patch protocol, because there obviously is a lot more individuals that are using fentanyl, and sometimes some of it does hold the person. And I've seen a lot of the fentanyl patches as well.
Okay. Um, During the slides, you talked about the tolerance level, depending if they have high, low tolerance. How is that tolerance level determined?
In the assessment process, just to see whether or not a person is utilizing other alternatives or other things happening in their lives, and whether or not there's a bit of withdrawal when they're on a certain doses. So every day I would ask, I ask my patients, how's this dose? Is this holding for you? What's your usage been? And then that way we know what the tolerance might be depending on history. And they do share what they've been using with that open discussion, and then you'll know how much that tolerance is. And also with the new guidelines, when you look at it, every 2 to 3 days, depending on where that dose is, you can actually get reassessed, and that is recommended that it's left a bit more open. You'll see some clinics have a little bit more drop-ins to have that assessment process too.
Okay, thank you. A couple of questions around missed doses. So there's a comment here that if the patient misses 4 days in a row, can the pharmacist adjudicate 50% of the OAT dose under the original prescriber, or do they do it under their own name? Also, if the patient is on the starting dose of OAT, can the starting dose be continued after 4 days? I think
So
they may be wanting clarification on what you can do after if they've missed 4 days in a row.
yeah, so pharmacists can't really change anything right now. There's a couple of things you could do, right? Ensure that there is at least a backup phone of something right now. And again, try and connect. I mean, the clinicians are really good at connecting now compared to before. You can also have that discussion if you were to do certain things under your license, have a more thorough discussion, perhaps call the 24/7 line to walk through your thought process, document appropriately. And again, it depends on where you are, like rural and remote. Sometimes it's harder and you might have to make certain decisions.
Yeah, so there is that. So after 4 or more missed days, you have to cancel the prescription. It has to be canceled. And so if you can't reach the yeah, exactly. And if you cannot reach the prescriber, what about emergency supplies? And just the questions popped up around that. Do we have can they do emergency supply?
Again, that's under your discretion. And right now you have to cancel. So again, you have to weigh risk benefits. And I can't say for your own practice, but you have to document appropriately. And I know sometimes in certain conditions and in areas, even I've made certain certain decisions I have to document. But right now, as it stands, you have to cancel the prescription, and hopefully the prescribers will have a lot more connections in terms of providing their numbers, and it's a lot more now. BCCSU has taken over the training of the prescribers, and we've strongly encouraged access points, especially for community pharmacies to connect.
Perfect. I'm just gonna ask a couple more questions. Some questions around witnessing the first dose on an OAT prescription for methadone and SROM. Is this still the case? And if the prescriber requests complete carries on these products, what do we do?
Again, PPPs follow witness, and then there's a lot more discussion about that, and hopefully you've seen less of this. I know at the very beginning, about 6, 7 years ago, there was more of that happening, but we've been mindful of PPPs and also talking to the clinician prescribers about this a little bit more because we have our requirements too.
Okay, and transfers of narcotic prescriptions or CPP prescriptions. I know we didn't talk about that, but can it be transferred between pharmacies, and is there a limit to that?
It can be transferred. There's a Section 56 exemption for transferring right now. And what's very helpful, I mean, we have colleagues here that we transfer here and there too. What's really, really helpful is provide that original too. It's just really helpful for a cross check for safety as well.
Okay. Sorry, I'm going to ask one more question. So I know we talk about the addictions line, but can you give a little bit of a description of who is on the other side? Are they practitioners? Are they pharmacists?
Sure. On the other side, the practitioner line, it's actually physician colleagues that are spread across BC. So you have rural, you have remote, you have urban, really good people to talk to. And sometimes these guys are really need to talk to through your thought process. When you call in, you have to provide a PHN. There's an intake person that intakes, and then you might have to wait for a call back or not, depending on the situation. But it's really good discussion on what you are looking at. Maybe you're not sure, is the person going through withdrawal? A lot of our colleagues in hospitals use this line as well.
Okay, thank you. Okay, great. Okay, just a lot of questions on prescribed alternatives, but I think, like Mona mentioned, the focus of this is an OAT, but stay tuned because there will be a lot more information coming out. And we will put a link as well in one of the resources. You might have seen the Access to Prescribed Safer Supply Policy Framework. There's some information about that as well. So I have put a link in the chat box. Be really grateful if you just could, thank you so much. Just answer those few questions and you get your letter of completion. I just really want to thank you, Mona. It's a lot of information. And I know we're sort of trying to catch up because this is like a really fast changing landscape. This session is recorded, so people be able to review this. I also want to really thank Cora and Amanda from BCCSU. They've been doing all the sort of the background there. So yes, any questions, just email info@bcpharmacy.ca and we'll get to them. Otherwise, enjoy the rest of your evening. Thanks, everybody.